Please do go ahead, Dr. Sombo.
Okay. So last week's session was a session that I'm particularly passionate about. The Ministry of Health was excited to announce the launch and rollout of the Pediatric Stage campaign. For those that may not have joined the session, the Pediatric Stage campaign has 6 priority areas, of which the first one is pediatric case finding, with the hope that at least more than 90% of children that are less than 2 months have an EID test done, those that are exposed. We were also encouraged that we will be using more and more of the Gene Expert platform. The second priority area for the pediatric stage campaign is retention. And how do we retain these pediatric patients? We have been encouraged to use family-centered approaches and a lot of DSP models and strengthen OVC services. Also, we will be using multi-mask dispensation for children that are more than 2 years. And for patients that are on TAFED and CLD, we should push to have them for 6 monthly refills.
Okay.
The other area that is prioritized in the pediatric stage campaign is orphans and vulnerable children linkage. We have to ensure that we offer more than 90% of adolescents and children living with HIV OVC services. The fourth priority area for the pediatric stage is ART optimization. For children that are more than 20 kg, please let's ensure we transition them to dolutegravir-based regimes. And we're excited to announce that we expect that very soon we will have dolutegravir 10 milligrams for children that are more than 4 weeks and more than 3 kg. The fifth priority area is viral load testing. We are going to move towards more and more testing on the point of care platforms, such as Gene Expert, so that we have quick turnaround times for our results. The sixth one, I know we are joined by Dr. Rachel Thomas, Dr. Muya, is technical assistant. At Davidson Hospital, at the University Teaching Hospital, we provide in PA to the whole country in the area of pediatrics. We're also reminded that we need to be calling 7040 for any issues regarding HIV services. At this point, Dr. Akosia, I'll let you announce the presenter for today.
Thank you very much, Dr. Sombo, for that great recap. I'm sure that it's a great reminder to most of us that are on the network, and maybe information to all of us that missed out on last week's presentation. So I'm very happy to introduce to you our presenter for this afternoon, and this is Dr. Mubiana, with a lot of expertise in HIV programming. Dr. Mubiana, are you on the call? Would you like to say hello to the network? Welcome, Dr. Mubiana. You could unmute yourself and just say hello.
Hello, good afternoon. I thought I was saying hello. I didn't know I was still muted. Thanks very much.
Thank you so much for joining us. We're happy to have you share with us this afternoon. Would you like to share, or we can go ahead and share for you?
Let me share. Or you go ahead and share.
All right. All right. Thank you. Thank you very much. We'll ask Dr. Mubiana to just go ahead and proceed with the presentation. Thank you.
Thank you, Dr. Ziambo. So today's presentation is on early infant diagnosis. I know this is a presentation we've had before in the past, but we've added a few more highlights to the presentation. We can proceed. So the three objectives for this presentation are to explain the national guidance on EID, to discuss challenges that are faced in EID, and also to describe evidence-based solutions and best practices to achieving high EID success rates. So looking at the guidance on early infant diagnosis, for us to be able to identify a child with HIV infection, it's important, first of all, to follow up a mother with non-HIV infection. So follow-up of infants born to women with HIV infection is very important. And for women who are presenting in labor and they mention that they have a negative HIV status, it's very important to actually ascertain that indeed they are still negative, or they've had a recent test in the not more than 6 weeks before delivery. And it should not be verbal confirmation, but we should be able to see the result and confirm that it was indeed negative. If a mother is not able to present that result, we should go ahead and test the mother to confirm the HIV negative status. When you have a breastfeeding baby and the mother was previously negative, we need to follow up such women and make sure they have a repeat HIV test every 3 months. Because we have a lot of mothers who get new HIV infection while they are breastfeeding, and because they were initially negative, these are the ones who are transmitting to their babies because they are being missed. So it's very important to have repeat HIV testing on all breastfeeding mothers as well, every 3 months. If a child has a mother with unknown HIV status, you are seeing a child and the mother is not available, you can go ahead and offer the child an HIV test, but if the mother is available, you offer the test to the mother first before you can test the child, depending on whether the mother is positive or not. Next slide, please. So to confirm HIV infection in infants and children who are less than 24 months, we need to be able to do virological tests. This is because, as we know, rapid serological tests in children under 24 months will basically tell us exposure status. That's that the child is born from a mother with HIV infection, because they're testing for antibodies. So we may not be able to confirm HIV infection in such a child unless we do a virological test, which may be a nucleic acid test or just testing for viral other genetic material from the virus. So some of the nucleic acid tests may be point of care, which one of them is the MPIMA, or near point of care, which is a gene expert. And we are calling it near point of care because this is usually based in the lab, but it will be in the same facility where you may be collecting the specimen from. So it's as good as point of care because you can have the result the same day. The other test that we are doing is DBS, where we are collecting dried blood spots and sending them to a lab where they are processed by PCR. For older children, the diagnosis is made like adults using serological tests. So just to go through how a dried blood spot is collected from the foot of a baby. So when you look at the drawing there on the baby, the shaded areas on the sides, on the heel, are the ones you should target for collecting blood. And it's important before you start blood collection that the hands are washed and dried, and then you wear gloves. And it's important that the card that you are collecting on is well labeled. So the sites should be warmed and you clean with alcohol. And before you proceed with collecting blood, make sure the alcohol is dried So allow to air dry and wipe away the first blood drop. Then you apply the blood to the side with the printing only. It's very important to follow these steps because if the alcohol doesn't dry, then the blood comes mixed with alcohol. And if it's not well labeled, then it may not be processed in the lab because they won't be able to identify where it's coming from or who it belongs to. And do not layer successive drops of blood on the card. Just one drop per circle is enough, and avoid touching the spot with anything. Are we going to the polling question? We missed the first one. Anyway, so the following may cause invalid DBS samples except A, inadequate sample, B, layered sample, C, now I can't see, using one drop of blood per circle, yellow rings around the blood, that's D, or clotted blood. So the following may cause an invalid DBS sample, except which one?
Thank you so much, Dr. Mubiana. Dr. Som, are you taking us through the polls? Okay, so we have 118 connections and only 40% have voted so far.
Only 40%. I'm sure we can do much more, much better than that.
Yeah, maybe there's. Okay, so we've got about 20 seconds more before I end the poll. Okay, I think we can end the poll here. I'll just share to see how people have done. So, Dr. Mubiana, that's how people have polled. Most of them think C is the correct answer.
I think that C is the correct answer. Okay. Thanks very much for that. I think we can proceed and then we'll see how we answered. So what would be an acceptable DBS sample? First of all, identifying information needs to be written very clearly. You need to have the date when it's being collected. You need to have the patient ID and the patient name. And then you need at least 3 good spots in the rings. And you need to make sure the spots are dry. After drying, it should look dark with a uniform color, the way it's showing in the 5 rings at the bottom. So as we said earlier, avoid layering and make sure the foot is dry so that there's no alcohol mixed with the blood. So when you have specimens, some specimens may be sent back as unacceptable if they can't be read, the labeling is not okay. If you don't have enough blood, or if you have layered or clotted blood, or if you have serum rings around the blood, which may be due to squeezing the foot too much, or also due to alcohol not being dry on the foot, or if you have small dots of blood as it's showing in the last demonstration on the card here. And the possible reason may be that the blood clotted when you're dropping on the card, or more than 1 drop was applied to each circle. So each circle should just have 1 drop for you to have a proper specimen. So all these examples we have on the right, in the middle column and the right column, are examples of unacceptable DBS cards. We can proceed. So what are the testing time points for a child who is under 24 months? As I said earlier, anyone under 24 months will need a virological test to confirm HIV infection. So at birth, for a child who is born to an HIV infected mother, we need to collect a sample for a virological test at birth, or at least within 6 days of birth. And then the next time you're collecting a sample should be at 6 weeks. That's if a child was negative, and you continue collecting these samples at 6 months and at 9 months. That's nucleic acid tests. After 9 months, at 12 months, you collect a rapid test, a serology test. And if it's positive, then you go ahead and do a nucleic acid test. And this applies also at 18 months and at 24 months. You do an antibody test first before you do a nucleic acid test. If a baby continues to breastfeed, you need to do another test at least 6 weeks after breastfeeding cessation. We can proceed. Now, there are situations where ideally we should all be having our nucleic acid test results within a reasonable time for us to make decisions about treatment. But there are situations where this may not be so. So you need to make a decision where to start treatment or not. And so you make a presumptive diagnosis of severe HIV disease. And this should only be made. The only reason we should be doing this is we want to make a decision to start treatment. So if someone is stable, but they have a few symptoms, we can't make this presumptive diagnosis unless someone is ill enough and we need to start treatment and we don't have a NAT result. So to make this diagnosis, you need at least 2 of these features, which may be oral thrush, severe pneumonia, or severe sepsis. Or you may have AIDS indicator condition, but a child needs to have an antibody test that is positive, or the mother may have a positive test. Other supporting features which may support the diagnosis of severe HIV infection may be if you have a CD4 count, it will be less than 25%. That may support the diagnosis. Or if you have a mother who has advanced HIV disease, then that may also support your diagnosis. So even when you do this, it's very important to try and confirm HIV infection as soon as possible using a nucleic acid test. So just because you have done this doesn't mean you've made a diagnosis and you stop there. You still need to confirm with a nucleic acid test. Can we proceed? So when you get a PCR result, it may say the results may read as not detected, which means that it's a negative result, HIV infection hasn't been found, or detected, meaning it's a positive result, HIV has been found or is HIV infected, or it's an indeterminate result, meaning that it was detectable target, but the level of virus is too low and could potentially be a false positive result. And this may need to be repeated then. Or you may have a discordant result where the first test you got was positive. And remember, according to the guidance, with the first positive test, you start treatment, but you also collect one to repeat to confirm the HIV diagnosis. So the next one comes as is negative. So you have a discordant result. Next slide, please. So we get to we get the third question. In an infant with an initial DBS positive result, who was started on ART and a negative confirmatory result, what would be the next course of action? So the first one, you stop the ART and follow infant until 24 months, or you stop the ART and discharge the infant from care. You continue the ART and repeat the NAT immediately. Continue the ART and repeat the NAT at the usual infant testing time points, and none of the above.
Okay, so we can go ahead and poll. The network is now encouraged to just speak out which one is the best answer. If an infant with an initial DBS positive result was started on ART and the negative confirmatory results, the following is the correct action. Stop ART and follow up infant until 24 months. Stop the ART, discharge the infant from care. Continue ART and repeat NAT immediately. Continue ART and repeat NAT at the usual infant testing times, or none of the above. So we can pick which one we feel is a correct answer. All right, thank you so much for those polling. I will end the poll, and just share how we have done so far. So, Dr. Mubiana, most people think it's C, as you can see from how people have polled.
Thanks very much. I think we have an experienced team here.
Yes.
Yeah, so why are we repeating an HIV test when we have a positive result? With improving PMTCT, the positive predictive value will decrease with reduced prevalence. So as the prevalence of infection reduces, our positive predictive value is actually reducing. So when you look at this slide, just click again. With a prevalence of 5%, we have false positives of 10.3%. But as it reduces to 3%, then the false positives actually increase to 16.4%. With very low prevalence, around 1%, you find the false positives are as high as 37.6%. So as we are improving our PMTCT programs, it's very important to actually make sure we are confirming HIV infection in these infants. Otherwise, we'll be putting a lot of infants on treatment who have a false positive test. That's why it's important to always repeat, even if you have a first positive, the second one should also be positive. But it doesn't mean we delay the treatment. We still start treatment with the first positive test. So we need to confirm just to make sure that the people who put on treatment remain on treatment because they're infected, and also to prevent putting those who are falsely positive on lifelong treatment. Yeah. We can proceed. So how do you manage a discordant result? When a confirmatory NAT is negative, a third NAT should be performed before considering ART in its interruption. So as soon as you get your a second test which is negative, you immediately collect another specimen so that you send to the lab to see how if the child is infected or not. But you don't stop the ART. You only stop the ART if the third NAT is also negative. But you should always consider the clinical presentation of the child and assess if there are signs and symptoms suggestive of HIV. And when you do stop ART, just agree on a follow-up plan with the caregiver, explain carefully what is going on, so that in case you really missed an HIV infection, you'll be able to re-enroll the child into care and probably reconfirm the HIV status by repeating the test. So if you stop ARVs on a child who has been on treatment, you'll get rebound viremia in about 8 months of interruption of ARVs. So if the child was infected and you're following up the child, you repeat the test 8 months later, you should be able to detect HIV infection if indeed they were infected. If you stop treatment but the child develops signs and symptoms indicative of HIV infection, you should go ahead and repeat the NAT to find out if they were HIV infected but you missed it. So breastfeeding and continued risk of transmission require follow-up and appropriate testing throughout the period of risk until you have the final diagnosis. So this can be a difficult issue to deal with, but it's very, very important to communicate with the caregivers so that they understand what is going on. Otherwise, they may lose confidence in the system. Next slide, please. Next slide. So from the point of care test, what we have now, we are also doing GeneXpert in some facilities. These are usually placed in labs, but they're based at the facility and the results can be available in a day. The print is very small. I don't know if we can see, but EID by GeneXpert is something we can consider almost point of care. So it's called near point of care. It's not called point of care because it's not where the patient is, but it's in the lab. But it's near point of care. So with the first result, which is negative, you consider them as negative and these are sent to the facility and the patient is followed up just like the way we're doing it on the conventional PCR. For positive results, again, you follow them up as we are doing it for conventional PCR, and these are reported to the clinician as positive. So basically, it's the same procedure. When it's positive, the lab reports to the caregiver to bring the child to the clinic, and they tell them they're positive and ART is initiated. If a test sample on GeneXpert is negative, that's the repeat one, then you have a discordant result the way we have it on the other platform for the conventional DBS. And again, if you have a negative confirmatory test on GeneXpert, then this sample is actually prepared and sent to the lab for a conventional lab PCR test in the lab. And when the results comes back, if the confirmatory GeneXpert test was negative, and then the PCR from the lab comes out negative, this is reported to the client as a negative test. However, if it comes out as positive, then this is reported as a positive test for the infant, and the ART is continued. For the one it comes out as negative, then you may consider stopping ART, but following up the child as we discussed earlier in discordant results. Yeah, so for GeneXpert, if it's positive, they repeat. The confirmatory test is again a GeneXpert. If it's positive, you continue treatment. If it's negative, it is sent to the lab for a PCR. If it comes out negative, then you consider them as HIV negative. If it comes out as positive, then you consider them as HIV infected and you continue the treatment that you started. I hope that is clear. We can continue. So for the last question, HIV-infected infants' ARV prophylaxis can be stopped for the following infants. A, at 6 weeks if never breastfed. B, after 12 weeks if breastfeeding and the maternal viral load is less than 1,000 copies. C, at 12 weeks in a never breastfed infant. D, at 12 months in all breastfeeding infants. E, A, and B.
Thank you very much. So we're inviting the network to pour their questions to pick which one is the best answer here. Is it A? So the question is HIV-ARV prophylaxis can be stopped for the following infants. Is it A, at 6 weeks if never breastfed? B, after 12 weeks of breastfeeding and the maternal viral load is less than 1,000. Then C, at 12 weeks in a never breastfed infant. And then D, at 12 months in all breastfeeding infants. Then E, A, or B. A and B, sorry. So we're looking for participation from the network. Please do feel courageous to try and attempt an answer. Thank you so much. So far, most people have picked E, and we have about just about 50% participation. Okay, I will end the poll and just share how we have performed. So, Dr. Mubiana, that's your score. Most people have picked on E.
Thank you. On A and B, okay. Thanks a lot. So we'll proceed with the next slide and see what it says. So for ARV prophylaxis in an HIV-exposed infant, as you are collecting your NAT at birth, we'll start the prophylaxis of AZT, 3TC, and nevirapine. So if someone has never breastfed at 6 weeks, you will be stopping the prophylaxis. Most of our population is breastfeeding, so you'll continue the prophylaxis up to 12 weeks. If the mother is going to be suppressed, you do a viral load on the mother. Remember, we are doing viral loads in mothers who are breastfeeding every 3 months. So at 12 weeks, if the mother has a viral load which is under 1,000 copies, which is our suppression rate, you can stop the prophylaxis for this infant. However, if the mother's viral load is high, it's not suppressed, you continue the prophylaxis and you will give it until 1 week after breast feeding exposure to breast milk. Okay. If the NAT is positive at any particular point, you will stop the prophylaxis and start treatment. I hope that is clear. So some of the challenges in implementing early infant diagnosis, this is not this is not exhaustive, doesn't include all the challenges that we face, but some of the challenges that we have found as we are implementing is a human resource capacity. Sometimes, especially when it's DBS collection, our staff may say they're not trained. Sometimes we don't even have enough human resources to actually do the work. And many times we are finding over-task shifting of EID services, DBS collection, counseling. We are finding that this is all shifted to lay health workers and there's no supervision. And this becomes a problem because sometimes they may not know when they need to act. It's very important as healthcare workers in MCH facilities that even when we are working with lay workers, we're actually working together, we know what's going on and they're being supervised. Another challenge that we keep facing is recurrent stockouts of supplies, and one of them especially being DBS cards. So that really affects our performance and diagnosis of infants because then they can't be, we can't collect specimens. Long turnaround time is another challenge in some facilities where the results take long to come. Sometimes there's a problem in getting them to the lab, but I think nowadays we have quite well-established courier systems. Sometimes they are delayed at the lab, maybe due to work overload. And then we may also have loss to follow-up of HIV-exposed infants. They don't come back. Remember, testing, we are going on up to 24 months. So I think it's very important to educate our mothers not to get tired and keep coming until we've established the final status of the mother, of the baby, sorry. And also now we have a lot of increased postnatal transmission during breastfeeding due to new HIV infections in the mother. So these are the infections we may miss in the child if we are not routinely testing the mothers. So what are some of the interventions that can be put in place to overcome some of these challenges in EID? One of them that I think we are already implementing is following up infants as cohorts. This is cohort monitoring of HIV-exposed infants. As you are following them up and recording them in the infant 0-23 months register, according to the month that they were born, then they are followed up and they are tested at the particular time points and recorded in the register until you get the final outcome for each infant according to the birth month that they were born in. Also, use of appointment systems is very important. We do appointment systems in ART, but for some reason, I think MCH is neglected. So we can actually have appointment systems even for HIV-exposed infants so that they know exactly when they're supposed to come to the facilities. And as we are doing appointment systems, let's make every effort to synchronize the mothers and the infants' appointments to reduce their burden of coming to the facility so that they just do one visit for themselves and the infant. We can also use SMS messaging or phone reminders before appointments just to make sure they come back to the clinic. Use of mentor mothers, or in some situations, in some places called mother to mother. These are HIV infected women who are motivated to offer adherence support to their mothers and also counseling so that they encourage them to take medicine and also to follow up the baby until the baby has final outcomes established. Also peer pairing with the pregnant woman in what was called in Malawi the Tengate model, where a lay counselor is paired at antenatal booking with a pregnant woman and keeps track of this woman until the woman has delivered and the baby has been followed up until 24 months and you've established whether the child is infected or not. So during this peer pairing, the peer actually supports the woman, make sure they don't miss appointments. If they miss appointments, they are followed up or they are called. Also, use of point of care technologies, I think, is very important in strengthening EID, as long turnaround times I think is one of the important reasons why we lose mothers, because they come, collect specimens, and the results take long. So when you have points of care technology, that helps to improve performance in that area. Next slide. So just to summarize the key points, the first one, follow-up of infants born to HIV-positive mothers for rapid identification of HIV infection is very important. And the testing time points for EID for breastfeeding infants is at birth, at 6 weeks, 6 months, 9 months, 12 months, 18 months, and 24 months, and also 6 weeks post breastfeeding. So from 12 months onwards, you're doing a rapid test first before you do a NAT. Sorry, my internet is not stable. And then initiate ART with first positive DBS result or NAT, and then you need to collect a confirmatory sample all the time you have a positive test. You don't just have one positive test and you forget about it. You need to collect a second sample. You can make presumptive diagnosis for severe HIV disease and start treatment in the absence of NAT, but always make every effort to confirm with a NAT as soon as possible. And provide ARV prophylaxis for HIV-exposed infants for as long as they are at risk. So if they are still breastfeeding, they need to be on prophylaxis until they've stopped breastfeeding. And we can implement some evidence-based solutions to track HIV-exposed infants until final outcomes has been determined. And those are some of the interventions that we were showing in the previous slides. Thank you very much.
Dr. Mubiana, I must say it was good to go over this and be updated once again.
I'm sorry, you're very faint.
Oh.
You are very faint. Maybe it's my internet, I don't know.
Okay, Dr. Kozia, can you hear me? Are we going to go over the poll questions again?
Yes, yes. You are now much louder. Thank you so much. Okay. Let me go to the poll questions.
Yes. So we'll just give a few minutes for poll questions, and we hope that we can open now after that. Interesting. So the first poll question, the following may cause invalid dry blood spot samples except A, an inadequate sample, B, a layered sample, C, using 1 drop of blood per cycle, D, yellow rings around the blood, E, clotted blood. We'll give it a few more seconds. Dr. Mubiana, do you want to take us through what the correct answer is?
Yes, so when you are collecting a DBS sample, you need to make sure you have an adequate sample. So inadequate sample, it may be invalid. You shouldn't put more than 1 drop on a circle, in which case you get a layered sample. If you get a layered sample, again, it will be invalid. Use 1 drop of blood per circle. That's the correct answer. So each circle should just get 1 drop. If you think it's not enough, we don't drop another drop of blood. You just need 1 drop per circle. So having 1 drop doesn't give you an invalid sample. So except, it means C is the correct answer. Yellow rings, yes, it will be invalid. Even clotted blood will be invalid. I hope it's clear.
It's very clear, Dr. Mubiana. We can go to the next poll question. Our second poll question is, in an infant with an initial DBS positive result who was started on ART and the negative confirmatory result, the following is the correct action. So you tested the child, they were positive. You repeat it to confirm, and you find that that is negative. What should you do? Should you now stop your ART and follow up the infant until 24 months? Should you stop the ART and discharge the infant from care? Should you continue the ART and repeat the NAT immediately? Should you continue the ART, repeat the NAT at the usual infant testing time points? E, none of these is correct. Dr. Mubiana?
So when you look at until 24 months, that one is not correct. Stop ART and discharge the infant from care. Remember, we said we need to reconfirm. So if you have one positive, one negative ART, and you repeat the NAT immediately, you don't repeat the NAT at the usual time point. Say, for example, you have that result at 3 months. Wait up to 6 months until you repeat. No, you repeat immediately so that you try and confirm whether indeed they are negative or they are positive. Remember, ART is lifelong, so it's the right decision. So the answer is C.
Thank you very much, Dr. Mubiana. So you will continue the ART and repeat the NAT immediately. Please, a reminder to us all, if you struggle to remember these things, we have 70-40. Let's not make on-the-spot decisions when we are not sure, because these are children's lives involved. We'll go to the next 4 questions. Our third poll question. HIV-exposed infant ARV prophylaxis can be stopped for the following infants. At 6 weeks, if the child never breastfed. B, after 12 weeks, if breastfeeding and the maternal viral load is less than 1,000 copies per mil. C, at 12 weeks in a never breastfed infant. D, at 12 months in all breastfeeding infants. E, A, and B. Dr. Mubiana?
Yes, so the answer is A and B. At 6 weeks, if someone hasn't breastfed, they are no longer being exposed to HIV, so you don't need to continue prophylaxis. You just give it for 6 weeks. And for a child whose mother has viral load suppression and they are breastfeeding, then you can stop the prophylaxis at 12 weeks. So the answer is A and B.
Thank you very much, Dr. Mubiana. This guidance is from the Zambia Consolidated Guidelines. So this is very specific to our country. We can go to the next 4 questions.
That's the last one.
Okay, at this point, we can take a few comments. Let's close the slide deck. Chatonda, we can close the slide deck. Are we able to take a few questions before we go into the case of the day? Any comments, any reactions? I know I saw Taonga Nyirenda. She had a question on the timing. Taonga, please go ahead. I believe a question was in the chat. If we can find that question.
I can read it, Dr. Sombo.
I think I've seen it. Why stop prophylaxis 1 week after cessation of breastfeeding compared to 6 weeks post-delivery and 4 weeks on PrEP? Do we stop immediately after the mother is confirmed virally suppressed at those post 12 weeks? Good question.
Hello, Dr. Mubiana.
Hello, Dr. Muya, you talk? Yes. So
Okay,
according to the guidance that is was developed for breastfeeding, remember all this guidance comes with evidence. According to the guidance for breastfeeding, it was found that stopping 1 week after cessation of breast milk exposure is adequate. I know it then raises the question, why are we giving it longer for the other exposures in prep and around delivery? Basically, I think everything has to have evidence for us to implement it. And the evidence for breast milk exposure is that 1 week after stopping exposure is adequate. I don't know if the other experts on the panel have anything to add.
Dr. Muya is our other expert, and Dr. Thomas.
Agreed. Evidence has shown that 1 week is enough with breastfeeding exposure. Once you stop the exposure, you can stop prophylaxis within 1 week. That's fine.
Okay. We can. Are
Basically,
there
says,
any...
do we stop immediately after the mother is confirmed virally suppressed, that is, post 12 weeks? So the mother comes and does her viral test at 12 weeks. When we get the result, we do go ahead and start. We don't get the results immediately. I'm sure it takes a week or two. And when we do receive the results, yes, we go ahead and stop the prophylaxis. Immediately we receive the results.
Thank you very much, Dr. Mubiana. I think this emphasizes why rapid turnaround times are critical, because if you are getting that viral load suppression 2 months after it was done, it may change the way you make that decision. So those point or near point of care tests are very critical for us to make decisions that will be meaningful and evidence-based. I'm not sure if we have any other participants, any other questions, concerns, or contributions, or any best practices from our network. As we do that, Shilenge, please prepare to share your slide deck for the case of the day. I note that we have 134 connections, which makes me think that we may have other provinces in this room, but that's okay. We are just starting. Any other concerns, clarifications? We have a very strong panel of experts, Dr. Thomas, Dr. Mubiana, Dr. Muya, Dr. Kozia himself, actually. And I noted that our director, Dr. Kankasa, also joined. So this is a very good time to ask questions. So Noreen has a question.
Sombo, Dr. Sombo, we also have Sister Fabi here, one of the very good nurses who will give us a nursing perspective.
Sister Fabi, do you want to talk about that? Because there's a question in the chat box from Noreen, who is asking, before Dr. Fabi comes in, what do you do if confirmatory is negative, but immediate test result after confirmatory is positive? So if you start, if you do something else outside the guideline, what do you do? What do you do if your confirmatory is negative, but then you repeat it and you find that it's positive? Any reactions to that, Dr. Thomas, Dr. Kozia?
Oh, Dr. Sombo, these are questions that will even come after this particular case. Perhaps we could have the case presented, then we'll go into details about all those possible outcomes. Thank you.
Thank you very much, Dr. Kozia. So Noreen, just hang on to your question. This will be discussed later. So at this point, I think we can have our colleagues from Chilenge present their case. Sister Phoebe, do you have any contributions? I know you now have massive experience in dealing with this type of children. Any clarifications, additions?
Hello. So if the DBS becomes a positive again, I suppose this is the reason why we need to monitor these children. They maybe need to restart or do another DBS again to ensure that it's a really positive, and then restart the treatment. That's why we need to continue monitoring these children closely so that we are able to put interventions without delay. Thank you.
Thank you very much, Sister Phoebe. I'm sure this response will be further expanded. Dr. Mwampaja, the floor is yours.
Hello, Dr. Sombo.
Hello.
This is Maureen Mzumara. I just wanted to stress on the need of the viral road, which has been discussed. I feel this is very, very cardinal. And if mothers are not virally suppressed, really it all interprets on the services we are giving, the type of counseling. So we need to ensure that mothers are virally suppressed as early as possible. Otherwise, the child will be on prophylaxis for a long time, and we know the adverse effect of SZT, which we don't want to expose our children to. Thank you.
Thank you so much. That is, I think, well taken. Dr. Mpanja, please go ahead.
Good afternoon. Are you able to get me?
We can hear you very well.
All right, thank you. Yeah, so good afternoon, network. I'm Dr. Mwampaja from Chilenge General Hospital. I'm an HIV TB medical officer, and I'll take you through the case presentation for today's echo. We can move to the next slide. And so our case is of CK, a 2-month-old male who was born on the 30th of November 2020. The DBS at birth was done, though the results we haven't yet received the results. The child was then initiated on prophylaxis at birth, and then using the point of care testing machine, the child tested positive. That was on the 11th of January this year, during the time the baby was receiving the 6 weeks vaccines. Then a confirmatory DBS was collected, of which we are still waiting the results up to today. And the baby was initiated on ABC, 3TC, and Lopinava, and as well as Septrin, which was applied for 2 weeks. Then the follow-up visit was on the 25th of January, and the baby was given another 2 weeks worth of medication. The next appointment is scheduled for the 9th of February, 2021. So the baby at birth, the birth weight was 3.4 kg, and had received the vaccines for the vaccine scheduled at birth. And at the time the patient was seen, there was no presenting complaints, and the review of systems was unremarkable. The mother, who is GB, is a 23-year-old divorced para-1 mother who was initiated on ART, that is TAOD, on the 26th of March 2019. But apparently the client was just collecting the drugs without actually taking them. She was just packing them. Her last visit in main ART was on the 6th of April 2020, after the clients started being followed up from MCH when she conceived. She had a booking visit on the 20th of August last year, and she attended 4 antenatal visits, but there's no documented viral results during antenatal care. The patient was then captured during the 6 weeks immunization visit for the child. That's when we tested the child using the point of care machine. Then adherence counseling was given, and the mother was also reinitiated on ART, having defaulted, actually not having taken before, despite collecting. Yeah, on the socioeconomic history, she's a young divorced businesswoman who's living with her mother, and she's a Christian by religion. For the physical examination, the child weighed 5.2 kg at the time of the examination, and the rest of the history, the rest of the examination was unremarkable. We can go to the next slide. In terms of the follow-up, on the 11th of January, when we did the point of care testing, mother's VO was also done, which was at 59,900 copies per mil. And then, like mentioned, we sent confirmatory DBS for nucleic acid testing, TTH, which we are still waiting for the results. And that was the regimen that the child was commenced on, as well as septrin. The rest of the tests were not done. We can move to the next slide. We can move to the next slide. Hello.
Hello, we can hear you. Please proceed to your questions.
Yes. So our questions for this case, the first one is, what measures can we put up to ensure that pregnant and breastfeeding women are actually taking the drugs when we prescribe them? Then the second question is, how can we streamline the subsequent follow-ups to ensure that there's adherence going forward for both the mother as well as the child? And the third question is, how best can we improve the long turnaround time for NAT results? Thank you very much. Over to you, Dr. Sombo.
Thank you very much. This is a very well elaborated case. Just a brief summary. We have with us a child that was born in November. So the child is around 4 months now, unfortunately, to a mother who has been on paper on TLD, but is very poor at taking this medication, as evidenced by one, the fact that she's got a high viral load as of January of almost 60,000 copies per mil, and the fact that one of the tests that was done on the child, the only test which was at 6 weeks, was positive. So the child has been put off treatment pending confirmation. The team is concerned, how can we improve adherence in these pregnant and breastfeeding women? Because it has adverse outcomes such as HIV-infected babies. And they want to know, in particular for this case, how do they streamline the booking so that they encourage adherence? Their other concern is, how do we improve the turnaround time for the NAT test? Do we have any questions for Dr. Mpanga before we start tackling these? Any clarifications on the history of the mother or of this child?
Good afternoon, Dr. Sombo.
Please go ahead, Dr. Thomas.
Just a few clarification. What about the other immunizations? It says only BCG, OPV. And concerning the mother, she visited 4 times antenatally. I just want to know at what time interval was that? And then the other question, the labs. There is no investigations on the mother apart from the viral load. I just want to know, we don't have the facility or what happened, like the RPR, CD4, LFT, creatinine, hepatitis B. just those clarification. Thank you.
Thank you. Dr. Mpanga, do you want to clarify?
Maybe you can just repeat on the first two questions. I didn't.
The
only
first
got the third one.
question was, this child seems to have received a BCG vaccine and OPV vaccine. What about the other vaccines, the DPTs, the Hep B, the rotavirus vaccines, the pneumococcal vaccines? Did this child get them? The other question is, the mother had 4 antenatal visits. I didn't get what the question there was, Dr. Thomas. At which point did her viral load get done, or was she tested? Is that correct, Dr. Thomas?
No, this 4 antenatal visit, at what interval was that? Is it at 1 month interval? Then we had that time to do a viral load. That's one question. Then all the other baseline labs are not done.
Okay.
For the mother.
Is that clear, Dr. Mpanga?
Okay, so yes, regarding the first question, for the child is up to date with immunizations. She received the OPV 0 as well as the BCG at birth, and then she received all the scheduled vaccines at 6 weeks. Then, with regards to the investigations, we just didn't document for the mother. We only documented the tests for the child, except for the VO, which is the only one which is documented for the mother. Otherwise, the needed investigations or the mother follow-ups was actually done. Just that we are focusing the case on the child. Then, with regards to the antenatal care, I will need to follow up exactly in terms of the actual dates that that the mother was coming for antenatal on the 4 visits. Thank you.
Thank you.
Any other clarifications?
Sorry, Dr. Sombo, I'm failing to raise my hand. It's Maureen.
Please, Maureen, go ahead.
Thank you. I just noted that the mother was receiving ART from the general ART. Where did they diagnose her to be HIV positive? Was it during antenatal? And how are they providing the services at this clinic? What is it integrated in MCH, or they're referring to ART? It says last visit was in main ART on the 6th of April 2020. Oh. Okay.
Can I respond?
So
please.
Yeah, I've noted that. Yes. So this client had defaulted.
So this child is more than a year, actually.
Yeah.
So the question is, why this child is at least less than 2 years? Why are they back in the usual ART? How are they getting their drugs?
Okay, so the mother started getting a ART from main ART clinic at Chilenje General Hospital. Then after she conceived, that's when she was referred to MCH to continue the follow-ups. And up to now, the mother is still getting the drugs from MCH.
Okay,
thank you. I've noted that.
Yeah. Any other questions before we start asking our team to help our colleagues in Chilenje who were kind enough to...
Yes, Dr. Sombo.
Yes, please.
Yes, I have a question. This mother visited the clinic 4 times during antenatal. Why wasn't the viral load being done?
Okay.
Because
so
we have actually viral loads. We do viral load in a pregnant breastfeeding woman every 3 months. Mother visited 4 times, no viral load done on the mother.
Dr. Mpanga, any comments? I'm aware that obviously even when a case is presented, doesn't mean you are the one who did all the visits. But in your exploration of the case, did you manage, as you did a QI, to find why this woman on 4 visits we are coming to find this high viral load? What were the challenges at facility level that has led us here? Do you know why she didn't have a viral load?
Thank you very much. So that's a question that we also had. We're also questioning ourselves as where we went wrong. So this client, after she started being followed up from MCH, she actually changed her name, her surname. As a result, the profile which was in MNR is different from the one which is in MCH. So this was a client who was kind of hell-bent to just fulfilling the visits, but not actually doing what she's supposed to do. So as a result, those antenatal visits, she was more worried about the other routine services which are offered during antenatal, like the obstetric examinations and the like. But when it comes to issues to do with ART, she was not very cooperative. So no wonder, I think we didn't manage to actually impose in terms of doing the VO, because she was kind of not interested in the ART services.
Thank you very much, Dr. Mpanga. I can see you made a lot of effort, and that's why you've given us this case to get what is going on with how do we improve care for this woman, because she has more issues beyond ADIAS. Peter Singongo from Police Clinic, please go ahead with your contribution. Mr. Singogo, your hand was up. Okay, maybe there is a problem with he can't connect. But Dr. Bosco has a contribution, and he says, with a viral load of more than 59,000 or 60,000, it means this woman was not taking her ARVs because it's just too high, is what he's saying. The question to you, Dr. Mupanga, is did we screen this woman with the non-positive screening too to ascertain if she was not on ARVs elsewhere?
Just repeat the question again, the last part.
Maybe Dr. Sombo, allow me to explain it a bit with your permission. Hello, Dr. Sombo.
Please go ahead.
Yes, I'm saying the viral load was below 60,000 copies. And it is practically rare to have a woman or a patient, someone with on ART, sorry, someone who's HIV positive, not taking any ARVs and have this viral of 50,000 copies. Normally we found this such with maybe higher than this. And did we really screen if this one was not taking ARVs elsewhere? That's my question. Thank you.
Dr. Mpanga, is that clear? Would you like me to clarify?
I think it's clear. Let me attempt. So when we sat with the patient, she declined getting ART services from any other place apart from facility. From the time that she was tested positive and throughout antenatal, and even the postnatal services she's also getting from Chilenji. So as of according to her, she was saying she was not taking at all. That's the reported history from her.
Okay, thank you very much. Is it okay now if we deal with the questions they want us to deal with? Maybe Dr. Bosco, you can step in and say, and we can answer the first question together. How do they improve adherence in this woman?
Thank you.
How do they improve adherence? Yes.
Yes, for me, it starts with the treatment preparation.
because when we have not prepared a patient, a client to take lifelong antiretroviral therapy, we don't expect a good adherence. So I think we start with the treatment preparation, where we see a woman committing that I will be on this medication for life. I think that's the starting point. Treatment preparation, I submit.
Thank you so much. So one of them is that we need to prepare our pregnant and breastfeeding women before we give them treatment. Any other suggestions on how we could have done better in this woman? Peter Singogo, your hand is up again.
Thank you very much, Doc. Thank you. I would like just to concur with the Doc to say that we really need to prepare.
You can give them for Friday.
We really need to prepare the client adequately. That is explaining the disease process so that she fully understands what is at hand. It's very important so that our client, even if she goes, she really knows the consequences that may come as a result of not taking medication correctly. But again, going by the client that we have at hand, for me, I feel to say that the client may be difficult somehow. He really needs someone who really knows to do counseling in a tactful way so that that client can really fully understand the benefits of taking ART. Thank you very much.
Can I comment on that one, Dr. Zom?
Please go ahead. Then we can have Dr. Mwangelwa Mubiana. His hand is up. Please go ahead and comment, and Dr. Mwangelwa Mubiana can go and comment.
Thank you. Thank you very much for that comment. Indeed, even for us as a facility, it was an eye-opener that indeed we should not take for granted that actually these drugs that we are prescribing, that the patients are actually taking. So we really need to follow up and to make sure that as we are offering the counseling, the same preparation that the other speaker mentioned, that the client actually understands why, and they'll be ready to be adherent. Thank you.
Dr. Mubiana.
Yes,
thank you very much for that contribution. Dr. Mubiana.
Yes, thanks, Doc, for the opportunity. Yes, based on what Dr. Bosco made as a comment to say that this client has been taking some medication even if she has been interrupting. And since the pre-counseling maybe stage has already passed, I think to help this client, it is really to strengthen in the post-counseling issues to identify what are the current barriers that are making her not taking her medication. Maybe she may have disclosure issues. Maybe she may need someone to help her and follow her at home to really support her so that she understands the importance of taking the medication. So to me, I think she needs to be paired with one experienced counselor who can provide continuous adherence follow-up to see how she can be helped based on some of the barriers she may have in terms of taking her medication. Thanks, I submit.
Thank you very much. Some very brilliant ideas there. I hope Dr. Mapanga, we are getting some ideas from there. There's also a question of, did you assess if she had disclosed to her partners or other bodies? Dr. Mapanga, do you want to get that question? Then we can go to the second question. Did she disclose? Okay.
On that one, we need to follow up.
Okay,
not sure.
Thank you. Dr. Zico, who is an eco champion, has a very brilliant suggestion here. He says, let's also use case managers for this case, who are the food soldiers or community health workers who interact with clients more frequently and attend to the needs of the clients at community level. At this point, maybe we can have someone volunteer to answer number 2, where we are asking about how do we make this visit more palatable, for lack of a better word. How can we streamline the subsequent follow-ups to ensure adherence going forward?
I'll volunteer. I think at a maximum, a monthly visit will be adequate for this woman. If not, a 2 weekly visit will be also important. And I like the idea of case managers. When you have a case manager and we say every month the patient comes to the clinic, but the case manager is following the patient. So at the maximum one month. Thank you very much.
There's a proposal for frequent visits, but at the maximum monthly visits, because we know these patients, we may want to see them every day, but also there's a cost implication and we may end up frustrating her. So there's a suggestion of somewhere between 2 weeks to 1 month. Dr. Febi has a comment, and Sister Febi says that as midwives, we need to ensure that PMTC services and guidelines are in place starting from ANC, labor ward, and postnatal. So the continuum and cascade should be in place. So we need to pair these patients with experienced midwives and community workers in a zone to help closely monitor her. Thank you very much, Sister Febi. How can we streamline subsequent visits? So there's a suggestion we go for 2 weeks to 1 month. Are there any people who want her to be seen more frequently or less frequently? Because essentially she's going.
2 hands up there.
Oh, please.
Dr.
Please.
Mwanza and Dr. Rachel Thomas.
Oh, Dr. Mwanza, I thought it was an old hand. Please go ahead, Dr. Mwanza.
Yes, I think the frequency of visit will depend on the strategy. If we agree with the case managers or the pairing with either an experienced counselor or a midwife who will follow her, well, we need to come up with a plan in terms of if she comes every month, then the follow-up can also be made through phone calls or home visits based on how the patient feels comfortable. So it's a case which we need really to monitor closely so that we understand what is happening and we help the patient. Thanks, I submit. Thank you.
That's very thoughtful of you, actually putting the patient situation into context. So Infinix Hotline, as I said, please let's name our devices. Adherence counseling at every visit is also very vital in helping these pregnant and breastfeeding women. So Dr. Mwanza has proposed we look at the context. We can do some home visits, some phone visits, and some in-person visits. In the interest of time, is it okay if we answer number 3, which says, how can we best handle the long turnaround time for NAT results? We'll let one of the panel experts take this one, and then maybe some contributions from the network. Then Dr. Kozia can summarize the care for these patients.
I'll ask Dr. Muya to take that one.
Okay, Dr. Mubiana, you're putting me on the spot. I was trying to ask our lab team to find out how results are returned back to the Lusaka facilities. Because the last time we had such a discussion, we found out that people don't follow up results. As a result, they end up pending at our lab. But having said that, I think we need to find out how results are returned back to the facilities. I think that's the only way we can handle this issue. And then the other point is, I don't know at what time we're going to have the point of care machines to help us resolve some of these issues, where we can get results quite early and on time. But otherwise, in terms of samples sent to, so not only UTH, I think that's handling NAT tests. I stand to be corrected, but I know minor SOCOS does, UTH. SIDE does also used to do, but for those coming to UTH, I need to find out exactly what happens so that this process of waiting for results doesn't take that long. And since we are, this Lusaka, Chilenje is within Lusaka, I can get back, I think next time, so that we discuss or explain on this same fora how best we can ensure that we get results on time. Thank you.
And just an extra comment as well, Dr. Ziambo here. We also recognize that there are other provinces here, Mchinga, there are other places like Ruapula, there's Northern Province, probably also and having similar challenges in terms of turnaround of results. I do know that at the moment there is a text messaging system that in some of these places has been established, and that has seen some improvement in DBS results. So I think it's to begin to be innovative and leveraging on some of these technologies when it comes to results feedback. That's what I've noticed, especially the DBS system. There's some places where they're using, is it text message?
Text, yeah, that was being used here in UTH. We're doing that. We're sending it out by text.
Yes.
And then also, I think on DISA, I think they put some on DISA as well.
There's a DISA as well.
Yeah. So if we need to just ensure that people have accounts with DISA so they can check on results.
Yeah. And the follow-up is good using our books where we do register whatever DBS we've done, and making sure that we follow up. That also makes the two places accountable to each other. I submit, Dr. Som.
Thank you very much, Dr. Kozia. Are there any other suggestions on this? Dr. Mwanza, is that a new hand?
Yes, just in addition to what the colleagues have said, I would like also to encourage the facility staff to be more proactive in terms of following up results. Because you found in the same facilities, despite talking about the long turnaround time, you have got 20 samples, but you have received results for 10. What does it mean? Meaning the system is working, maybe there are a lot of samples in the lab. So people need also to be more proactive in getting a phone, just clarifying on 1 or 2 results. Then that way it will improve in terms of result return. Then last week in Kashu and Chilanga, we were informed that reagent for gene experts available, and orientation actually was planned to start today in terms of doing the DBS using expert. I don't know if you can shed more light on that, because it's one of the concerns we had in those districts, and we were told that they are doing the orientation. It was expensive to use the point of care, the NATs before, but with the gene expert, it's cheaper, and plan from the lab team have already been made in place. I don't know if you could shed more light on that.
Dr. Kozia, are you aware of those?
What?
Use of gene expert.
Use of gene expert. Maybe Dr.
No, I'm not aware of those.
Okay. Yes, I can comment on that. In our discussions with the Lusaka Provincial focal point person for pediatrics, it was mentioned to us that there's a plan to scale up use of gene experts in Lusaka sites. So that should improve our result return for Lusaka sites as well. So I think that's why they are starting with the trainings. So just also to add to the comments on result return and being proactive, I think it's very important to work closely with the labs where your results are being sent and have an understanding where at least they can expedite results which are positive, even as you wait for the rest of the results. We've done that before with our labs, and it has worked very well. so that you are able to get to initiate treatment on infants who are infected early.
Thank you very much. I think one of the key words that has been used is proactive. Let us be the change we want to see in the facilities. Let's not just fold our hands and say, oh, the lab is not doing its work, you know, and wait for people to come for TA and then say, but this is where the bottleneck is. So we need to continuously do our own QIs at facility level. But I think some good news in that they are scaling up these gene experts for viral load and EID in Osaka. Dr. Kozia, should I go ahead and summarize the responses unless there is another comment?
Yes, Dr. Sombo, some very, very excellent comments coming in from the chat box. Miriam has just said a very important aspect, that this is a divorced woman and maybe going through some mental issues, psychological issues, and all those things. And I'm beginning to see that I think the hallmark of all retention and keeping people around is having adequate social support to these clients. And that is social support in terms of the people at home, even the people at work. Now our environment in workplaces is very congested, very difficult to offer very focused care. But I think as we bring in the issue of SETA, which is talking about assessing, evaluating psychological care and mental health, I think that will also be able to bring out some of these people that may be undergoing a bit of a stressor situation, maybe depressed, and they're sort of giving up and not seeing the importance of taking treatment. So I think ensuring that in our care, we're more holistic, beginning to address issues of social support, and also that might also say that OVC services might be valuable in this particular case that we're talking about. So I thought I should just emphasize those two areas as people have contributed on the chat. Thank you very much, Dr. Somo.
Thank you so much, Dr. Kozia. Above all, thank you so much to Dr. Mpanga, who put this case together. It's not easy. And we say thank you. We have all learned so much from this. A quick summary of the recommendations from not only our panel of experts, but also all the other connections, because they are experts in their own sense. So in terms of adherence, we need to think about treatment preparation, patient context. What are the barriers and enablers and challenges for these patients? What are the disclosure issues? What are the possible mental health issues around these patients? With this corona, we all have mental health issues, so we should all be very sensitive and open to that. We should think about pairing her with an experienced counselor. But something very interesting came up, that in terms of streamlining her visit, you can consider a mixed method. Some visits, you can do them via phone, you check on her. Then others, you can use the community healthcare worker. Then the other visits can be in person, so that you are getting your 2 weeks, but not in the same format, so that the patient is not overwhelmed with coming to the hospital and being in our queue. A brilliant suggestion came out through the chats, even if I didn't read it, which talked about viral load champions who can help us in following up with results. And also let us use innovations such as text message. We don't have to reinvent the wheel. We all have text messages. Maybe this can also help us with streamlining, getting back results. And also let's be sensitive that most of us now, we can just get registered onto DISA. You don't need a lab person. You just have to go on to DISA and access these results. But I think above all, let's all be proactive in managing these patients. And Dr. Mupanya, you have shown proactivity by bringing such a case to our attention. But interestingly, Dr. Kozia now points out about OVC. I am passionate about OVCs because all the ECHO cases we presented in pediatrics, those children have turned out to be OVC. And it's good, it's a key stage priority area for pediatrics. So this child now falls under the category of OVCs. So we need to think of these things holistically. And with that, there is our start and end QR code. We want to thank you for joining today's session and for your wonderful participation. Congratulations, Dr. Kozia, the HW team, and all of us that joined this first decentralization eco session. Dr. Muya, Dr. Thomas, Dr. Mubiana for the wonderful presentation. Thank you. You always support us and you support our facilities and patients. We are highly indebted.
Thank you.
Thank you.
Our session for next week will be on retention. Dr. Mwango will be presenting. We'll see you on Monday next week.